So the Dr. Cookson, prominent psychiatrist here in Denver, actually made a really good point. Some primary care offices won't have the MD, won't have the social worker who can place mental health holds. So nurse practitioners, PAs aren't actually able to. So what are some other things you can do? You can call 911. The ambulance is coming anyway. Ask them to have a police officer. Police officers can do it. And so actually it's something that needs to be thought about if that is the case for your office. I personally, I would prefer to have a police officer show up to the office than, again, to trust that parent is going to take the child, or this person who's ambivalent is really going to seek care. So even though it seems yuck, I think that
you're in Denver.
The head of the CIT program has actually asked a number of us to create a minor baby CIT program for all officers to go through, so that they all have some training. It's not at the same level, it's not as intensive, but it actually, how do you deal with this kind of population? How do you deal with the agitated person? And that kind of thing, to be a little bit more compassionate. So, I mean, really you are the front lines. And so having curbside ability and knowing when you're uncomfortable. Because when you start to get uncomfortable, so the JD in me, again, bad hat's going on. When you're out, you're outside your scope then. If you're really uncomfortable, you're outside your scope. You need to be bringing in other people, as much as possible.
I'd say for kids it's a little different because they'll go untreated, and then they'll receive different kind of services through school too. So I'll refer to school counselors all the time. The kids are there. There's someone they can talk to. If you've got a kiddo with schizophrenia, they're all being seen by psychiatrists or some level of that. ADHD, they're not being seen by psychiatrists. And most kind of more simple depression and anxiety is not going to reach the level of psychiatry to just even making it to that referral. And then I always like to remind everyone that first line treatment for anxiety and depression is therapy. It's talking. And so if you can get that kid plugged in, that's where I use school counselors and that system as they're our number one referral source as well. So I think with kids you can plug into systems a little bit differently. And I think we could be more prudent times a million in our use of medications, whether you're a psychiatrist or a primary care provider. So I'm with Pat Bacon and other people on this psychotropic advisory committee for children in foster care and kids in state custody. They're all on Medicaid, and we have some problems in how we manage those kids. One, because so many are dealing with trauma, and we need to be looking at things differently. So I would say, as a primary care person, when you're dealing with younger kids, start with parents and school as a bigger resource than you think in terms of being able to connect them with their safety net. I think you should ask every time. It's quick. They can just say no. And so most of the time, no, fine. So I think the time you don't ask is the time you wish you had.
So the first part of that question, the PHQ-2, it's a self-report. It doesn't matter who administers it. It can be on when they're first walking in, and everybody gets a clipboard. They have to fill out something. Is your insurance changed or whatever? They have the PHQ-2. Anyone can look at it and rate it. It's 0, 1, 2, 3. 0, 1, 2, 3. So it's the end is it's between 1 and 6. Now obviously somebody will have to do something with that number. So it would need to get to the treater. And so who you want that to be, who gets it to the treater, I don't know. It is so simple. It is so easy. Every time really is, because you don't know. At the very least, I would say quarterly. Like if you really didn't want to do it every time, if there was some reason. It's really not intrusive though. I haven't really heard a lot of patient complaints about the use of it. With when I've talked to my friends who they actually use the longer version, PHQ-9. When you're doing your review of systems, when you hit psych, you're asking anhedonia and depression. So you can do it formally as a PHQ-2, but you're probably, when you're going through your whole review, you're probably asking it probably all the time, because I'm sure you're focusing on chief complaint, but then you're also doing a quick review of systems.
I have a question. I want to follow up on the doctor from Clinica's question to Rob and Sherry. She's in her office and wants to use school, has a kid or an adult, anybody, maybe wants to use school, family, other resources, psychiatry friends that she's befriended. And now you do have a whole bunch of friends up here, everyone, by the way, that you can curbside. But what happens if she calls her BHO, number one, or what happens if she calls Metro Crisis Center because she needs help with medication management for a schizophrenic patient or a bipolar 1 patient who's complicated? What response would she get from either of those scenarios?
So I think that if you call the BHO, we're going to connect you to one of our care managers and work with you directly, or then follow up very much the same way that Sherry talked about how Metro Crisis can follow up. Virtually a little difference in that. So I think on a case-by-case basis, that's what we'll do, is the care managers are available to do that. I think on a sort of a system or a practice level, what we want to engage too on sort of what is in preparing you for that, either on how to best use those case-by-case basis, or how do I get more integrated care into my practice? How do I partner with a behavioral health provider, or how do I hire my own person, or what does that look like? So we want to really hit sort of that individual patient level, but also we want to work with you on sort of the practice and system level as well.
So the reason I wanted Rob to go first, because if someone calls in and they have Medicaid, we'll have them call their BHO. Or we'll call the BHO for them, or work that way with Colorado Access. We actually had a case just today of a woman who was really trying to get into services and was getting these odd answers every time she called and going round and round. So we called the provider. We were getting these same weird answers. We finally called the care management team, and 3 of us got on the phone together and we got our appointment tomorrow. So there's a lot of things that we can help do to sort of problem solve. We don't always have that direct connect. But we do have friends that can help us with that direct connect. And certainly if Medicaid is involved, it's much easier. If you call me and say, I have a guy, he doesn't have any insurance, he's transient, whatever, he needs meds, I don't have a magic wand. So there isn't an easy answer, especially when it comes to medications. It's in kids I don't think any of us have the magic answers. But we have some paths to try to put you down.